Hello, everyone. Welcome to the Indiana Medical History Museum. This is the 2025 John E. Pless, MD, Memorial Central State Circle Lecture. Is that all the words? Dr. Pless was a pathologist based in Bloomington, Indiana. He was a very dear friend to the museum for a very long time. He passed away in 2014, and this lecture series was established in his memory. So that's why we're here today, and we're doing something a little bit different. This is a program that this is my colleague Norma Erickson. I'm Sarah Halter. I don't think I said that. We do this once in a while, and it's an opportunity for us to show off some of the interesting or kooky or scary things that we have in our collection. This building, so a lot of you probably know this. I think I know quite a few of you. We are housed in the 1896 pathological department of what was Central State Hospital when it closed in 1994. But this is 1896 when this building opened. It was cutting edge. It got a lot of national attention for how modern it was. It was one of the first laboratories of its kind in the US and the first to apply pathology to mental illness rather than public health issues. And so it was a big deal. They didn't have any money to modernize the facility though over the years. And so, over the next couple of decades, the things here started to become pretty antiquated. By the time the laboratory closed in 1968, everything was still the same as it was for the most part in 1896, with original furnishings, equipment, specimens, records, the library collection. We became a museum in 69 within a year, reopening with all of that stuff still here intact. And then we began furiously collecting more stuff. We have about 55 years worth of donated materials on top of all that stuff that the building was packed full of already when it became a museum. And so there's a lot of stuff that we have in our storage areas that you don't get to see on the tours. We try to pull things out for displays around the building. We take things to other institutions and do traveling exhibits, and we're sort of tiptoeing into online exhibits now as well. But we have a lot of stuff that we're really excited about that we don't get to show off as much as we would like. So this is what we're doing here today. Okay, so here we go. I think we're starting with Norma.
Right.
I'm gonna sit down and stop talking, and I'm gonna let Norma do her thing.
Okay, so my things aren't scary. I didn't know scary was a requirement or icky. But it's supposed to be things that are in our collection that people don't see very often. The things that most get brought out are things that at least a patient would see, have it used on them in some fashion or whatever like that. But my picks are items that the patient never saw getting used because it was in a laboratory that the patient wasn't in the laboratory, just the blood sample was. And so that's what I thought maybe would be interesting to you to see the gadgets and gizmos. Actually, they're not, because I think it has to be electronic to be a gizmo, but it's not. Is what?
Is there a definition?
Yeah, I believe there is. I believe it has to be electronic. And I think I already hit the wrong key down. I'm hitting the down. Isn't that what you want me to do?
Sometimes you have to just like,
Touchpads?
well,
Yeah.
sometimes you have to do that in order to make this work. Oh, but that didn't help.
That's not fair.
Well, all right, you keep talking.
Okay, so what I'm going to all these things are sitting out here on the table, so you can see that. But when it comes to blood, a complete blood count, CBC, you hear that on ER all the time. They're going to give a CBC. Okay, so how that developed and how it began to be a useful thing for physicians to know. And I think it was in the 1600s. Oh, it all counts. That's the name. Okay. Yeah. Okay. Yeah, so there's a lot of stuff in the blood, cellular components that do a very specific jobs, and there's a lot. And so here's what we're going to talk about. If someone says you need to count your red blood cells, how do you count 4.5 million in a milliliter? Or white blood cell, far fewer white blood cells in your blood. So does that show up at all? Oh, that's very pretty. It doesn't look good on here at all. So yeah, so here's a blood. This would be on a microscope slide, stained. Not gonna look that way in your body. That's all stained up. Okay. So yeah, so I feel like I'm in the middle of my talk, actually. But anyway, that's okay. It was around the 1600s that someone discovered, looking through a microscope, that there were these small little things. Even Van Leeuwenhoek, who he got in, yeah, there's red things in here. You called them red corpuscles. Those were the red cells. The white cells you couldn't see for a long time. It wasn't until like the 1800s when they actually saw there were white blood cells. And the Virot guy, he counted blood cells by putting a known amount on a slide and counting them all, which no, that's not a good idea. So Toma then in 1881 developed a hemocytometer, and you saw one out there, and we'll see one here, that was etched with a tiny little grid. You can't see it. A tiny little grid on the microscope that you could count then by following where the cells were on the grid. Okay. This is a tomoscope. It's round in the middle. The other ones I'm going to show you, it's not. It has special pipettes because that's how you count 4 million cells. You dilute the heck out of them. You water them down, and then you are able to count on the little grid that you can't see. So that's that kind of. This is from our collection, of course. And this is what I don't have to look at that. I've got it right here. Okay. This is an example of the grids that you would see on different kinds of hemocytometers. And the one that is up in the upper left corner is a Neubauer, and that is one that's most frequently used today. People still have to do this. If a cell count is very, very low, the instruments, the machinery, the instruments that can't count it. Someone has to do that. So you would have your blood sample loaded in there, very watered down. So you see cells floating around in those little squares. They're not floating. And then you count them. And then you do a huge multiplication, and then you know how many red cells you have. There's the Toma. They look kind of the same, don't they? But it was different. And then the Spears-Levy, that was for counting. There's two special white blood cells, eosinophils and basophils. Not very many of them at all in the blood, but they are important. You see a lot of them with people who have allergies and things like that. So that called for a different kind of a grid. So that's what the Spears-Levy is. So that's a little different. Well, there were some words. What did I say? Yeah, I did that. Okay. Yeah, the levy had twice as much volume. And that was what ended up being the evolution, was instead of just taking, here's this known amount, I'm going to put on here and do it like that. It was like, I need to know the volume that I'm looking at. And so it made a little chamber that the little grid was etched into on the slide, and there was a cover slip put on. It was very precise at exactly the volume of diluted blood you were putting in there. So you could be accurate on that count after you did your huge multiplication. Okay, so there's the, you can't see it there because it's tiny, but that's the thing right there. It's under the microscope. Oh, the counting, yeah. So when the blood gets in there and the cells are like, here's some, some, you count them. And then there's rules. You have to follow the rules. If a blood cell is touching the edge, do you count it or you're not? Is it in or is it out? Well, the rules are, and it depends upon where you were. You count the line on the left top and the line on the right, or you count the line on the bottom and the line on the top. You know what I mean? And that's how you get an accurate number. Pipettes. Okay, this is how you make your dilution. You see that one of them has the red thing on the inside, and then the other one, it's hard to see, but it's a little white thing. Okay, so that's what you make your dilution with. So the tubing then gets inserted on the end of here. And then the tubing goes in your mouth. And you put the sample in the blood. And you pull up the blood into the pipette until you hit the little line that's about, hey, I got a pointer. I have a real pointer. This is a pointer. You draw it up to, I forget which one it is, like up in here. And then if you went too far up and you needed to adjust it down, you just tap it against your fingertip, the blood on the fingertip. Don't put a tissue on it because it's going to suck the water out of it. You have to do it on your finger. And then you suck the rest of the way up with your diluent up to the top. So now you've got a little bit of blood and a whole lot of fluid, and then you mix it for several minutes. And then you load it onto the hemocytometer and you let it sit for several more, 15 minutes. And then you go in and you count. So you see how long it takes to do a blood count? Oh, and that was just for the red cells. And you gotta do the same thing for the white cells, right? Long, tedious task. The slide I showed you earlier, the pink and the blue and all that, the staining techniques, the people who were counting, that was before they even had staining techniques. That was 1879. The first ones were like, and most commonly in the blood cells, white stain is used because it stains both the acidic and the basic ones. Yeah. Okay, so you know what you're seeing? You see the red blood cells, that's easy, right? Okay, these blue things are white, they're white cells. That's a neutrophil. Those are the infection people. Those are do the work, okay? And that's actually a poly segmented. And then there's a lymphocyte, and then there's another seg over there. And the little dots are your platelets. Okay, so it's important to know what kind of white cells you have, how many of them, like that. So this is the other thing. This is what sparked this, was this really old counter that we had. But this is a newer one than the one that you see sitting out there. And so you see the keys, and there's even little pictures on this one of what finger you push with what cell you see. This is another one. This is great. This was on eBay. Someone wrote it in. Okay, so this finger with the segs, bands, lymphs, and it's just like typing. You know how when people type, you just know what finger, say, I still do it. I haven't done a smear in 25 years, but my finger knows where to go. And then, of course, it counts up all of them. You only count to 100, and that's a percentage then. You don't see basos on there. And the monos and the eos, there's not very many of those. So you don't need, your pinky just kind of jumps out and gets that one. This is a little bit, this is a kit that, like I showed you, that keeps the pipettes, whatever. This is a German one with the wonderful German word, because they put them all together. Blutkorporationapparat. Blood corpuscle machine or something. Okay, so I'm coming to the end. This is not in our collection. I wish it was. That manual counting, although I did say it happens still with low counts of cells, has been replaced by electronic counting. And it was a very, very big, I think one of the biggest developments in the laboratory was what they call the Coulter principle, that it was developed by Wallace Coulter. And what it did was you pass an electric current in a solution, and if a cell were to come in, get in the way, it's going to change the voltage. So you can count by that voltage change. You can even tell size of the cell. And the amazing thing is they made it so it would go through an aperture in a piece of glass, one cell at a time. Count, count, count. And of course, they're all bigger and better. And they even do the white blood cell differentials now too with flow cytometry, laser. Yeah, so that would be another whole thing all in itself. About that, because I'm done, really. The great thing about the culture counter is the story. It's a story. I think it's a good story, a true story. He had been in the Far East. He saw med techs doing this blood count that took them so long to do. It was very tedious task. And then after the atomic bomb was dropped, that was one of the things they had to do blood counts on people and bone marrow on people. And he thought of these people who had to do these manual tests, you know, that would take so long to get the answer to, that he wanted to come up with a way for it to be better. And so that's what he did. Took it to the patent office, and because the hole was the big thing, the hole was the important thing. Attorney says you cannot patent a hole. But he did. And that's it. Sarah's picks.
I have two very different things for you today. As usual, I couldn't decide. There was actually a third thing too. I'm going to go ahead and tell you about it, even though I didn't pull it out because I don't have like a presentation ready for it. But maybe next time you will get to see the rectal heater. We'll do a demonstration. Not on me. We'll need an audience member to volunteer. Okay. So let's see, what have I done here? I'm missing something. So I have a favorite Civil War era surgical kit, and that's what this is. So the box is open in there right now. This is what it looks like when it's closed. You can't see the plate on it. I'll have a close up in just a moment, but the outside here. So we have a lot of these in our collection. Probably dozens of them. They're all a little bit different. Some are smaller, some are larger. This one is my favorite. This is the one that I take with me to scare children with. It's in really beautiful condition. It's pretty extensive. It has a lot of stuff in it that you don't always see in every surgical kit. It is a little scary, which I think is fun. Nobody gets hurt. We don't let people play with the knives. So I think it mostly scares adults though, not the children. I had the great pleasure of taking this along with a whole bunch of other Civil War era medical things to a Civil War themed summer camp for 12-year-olds in northern Indiana. And we spent the whole day, there was a medicine day, and it was the best day ever. I spent all day using all of these cool artifacts to teach these 12-year-old kids about Civil War medicine. And then I taught them all how to amputate each other's limbs in case of emergency. I got a call about a week later from the camp director who had been receiving calls from the parents all week. And I was bracing myself to be in trouble, but they were disappointed. They were disappointed that we hadn't invited the adults to come. So it worked out great. But this is the one I took there. But this example is also special because we actually know quite a bit about the man who owned it originally, and that's not the case with all of our kits or all of our artifacts in general. So I had started with just the name that you can't see yet on here. Here's the kit when it's open. There's a little tray that comes out, and then there's more underneath, so you can see here. Here's a close-up of the little plaque. It belonged to a physician from Darlington, Maryland. You can see that here on the plate on the lid. Dr. W.S. Forwood, which sounded to me like a made-up name. So I started digging, and I found quite a lot about him. The WS, first of all, stands for William Stump, so that just makes his name even more strange, I think. It's not clear so he trained through an apprenticeship. He had an apprenticeship with a Dr. Robert A. Archer. He also went to college, but it's not clear what he learned there. So we don't know if that was medical training in addition to his apprenticeship, or if he just became a doctor through the apprenticeship, which is very common at the time. He was born, I think, in 1830, so this would have been in the early 1850s. And here he is. William Stump Forwood was born on January 27th, 1830 in Darlington. He lived there for most of his life, except for a few years here and there, when he was sent by his father to Gosport, Alabama, which I've never heard of and have not done any investigation into. But apparently his father owned some property there. There was a business, and Dr. Forwood, who wasn't a doctor yet, was in his first stint there. He was sent there to run this business. He had some health issues, and they were trying to get him somewhere warmer. He did get married. So he was in Alabama from 1848 to 1851, and then again later in 1870 to 73. His first wife, Pamela Wilson, died in childbirth in 1860. The baby also passed away, so he had no children with her. He had been married not quite 3 years at that point, and he remarried a woman named Addie Bond, and he did have 2 daughters with Addie. Dr. Forwood was also very active in medical societies, in both places that he lived. He published a fair amount. In addition to practicing medicine, he was also a local historian of Darlington. I came across a National Register application that his work had been heavily borrowed from in this application for a historic district out there. He published this article. This is just one of many that he published. This is the Atlanta Medical and Surgical Journal, and this is about a case of cerebral herniation. This is in which the skull doesn't form all the way, and the part of the brain is on the outside of the skull. So this was a case that he had encountered, and he wrote it up as an article and submitted it to the journal. The baby was one of a pair of twins. The other twin was perfectly normal. The article is a description of what he observed in the baby and his review of the literature on the topic. In this case, it seems that the exposed brain tissue was covered with skin and even hair. And he described it as, quote, a large, elongated, piriform tumor. Piriform, I looked it up for you. It means pear-shaped. And the baby only lived 19 days. He wrote about other things too, unfortunately. Dr. Forwood was also very pro-slavery, and like many physicians at the time, he made a lot of medical and ethnological arguments in support of slavery that demeaned and dehumanized Africans. I don't have an example of that to show you, but it's out there. And I don't know yet whether Dr. Forwood served in the Confederate Army or it had done any military service. I haven't found any evidence that he did, and his obituary doesn't mention it at all. I also don't know how or when his surgical kit ended up in Indiana. The only connection I found to Indiana was through his brother, who was in the Confederate Army and who ended up here at Camp Morton. So there are letters going back between them from that time. And so now I'll shift my focus a little bit from Dr. Forwood to the kit itself. By the time the Civil War started, medicine was really just starting to become a more professionalized field in a lot of ways. More progressive physicians were recognizing the value of scientific investigation over superstition and the application of scientific principles to the study of disease. Physicians' tools were becoming more specialized, more useful, and sometimes, but not always, more patient-friendly. Many of these instruments in the kit were used in one particular procedure. It was the most common surgical procedure performed by Army surgeons on both sides during the Civil War, and that was amputation. It was the most common, not just because so many injuries required amputation, but also because there really weren't a whole lot of other kinds of surgeries being done. That was something you did if you were desperate. The infection rates were very significant. There was no way to control infections. We didn't have antibiotics yet. And so if you could survive without surgery, you probably wanted to do that. The surgical instruments and the hands that used them were dirty, even if they looked clean. And infection really was almost inevitable anytime an incision was made. These were also often done in dirty environments. Proper hand washing was not a high priority. Sterilization of instruments was not a thing yet. This is before the germ theory of disease, and it's before Lister's work on antiseptic surgery. So infection was inevitable both in surgeries and for wounds, which is why amputations were so common. If there was any evidence of infection, or if the damage couldn't be repaired, it was easier and safer to just amputate and move on. You had to be quick though, and these guys were very quick. If they were good, they could perform an amputation in about 15 minutes or less. These amputation knives were used to cut through soft tissue. Hopefully you can see them okay. If not, take a look on your way out. The bone saws, you can only see one in this photo. There's another one underneath the bone saw that you see here, and you can see it in the case since we removed them. But these were used to cut through bones, obviously. The larger one is for larger bones. The smaller one is a metacarpal saw, which was used for fingers and toes. Lots and lots of fingers and toes were amputated during the Civil War. And this is pointing to an empty spot in case you thought I just put it the wrong place. Forceps are used for a lot of things. The forceps in this kit are missing, but they haven't changed a lot. The ones originally in this kit were fenestrated with an opening on both sides. You can tell that from the indentation that they left in the kit. These are handy as kind of a multi-purpose tool. They're used to grasp or hold things, pinching off blood vessels, removing foreign objects from a wound, that sort of thing. And one special type of forceps, we do have a lot of these in the collection, but there's not one in that kit. These were used by Army surgeons quite a lot too. These are bullet forceps, and there are different kinds that came in different sizes. Some had pointy tips like a tenaculum, that's what you see here. Others were more rounded, and they would use different types depending on what kind of bullet they were trying to remove. So if it was a round ball, you would use different forceps than you would use for like a conical mini ball. The tourniquet was an important piece to have. This was used to cut off circulation of blood to a limb to prevent excessive bleeding. They were used to stop bleeding from serious injuries on the battlefield, but also during the amputations in hospitals for the same purpose. And there are different kinds of these as well. The one on the left is kind of a makeshift tourniquet. It's a rope and a stick, and that's all you really need. It's low tech, but it's effective if it's used correctly. The problem with this one is you have to actually hold it in place, which is not convenient. The other one is like the one that's in the kit that you'll see in there. It's a screw tourniquet, and it's easier to use. It doesn't require constant pressure from the person who's applying it, and it locks in place so that you don't have to stand there and hold it. This curved instrument is a tenaculum. These are another kind of multi-purpose tool. During surgery, they're used for a few different things. They come in a lot of different shapes and sizes. You can use it to pull or push things out of the way, or as an amputation, you could use it to hook around blood vessels to pull them out so you could tie them off, or use like surgical sutures to tie them as well. And that helped eliminate the bleeding as well. And everyone's favorite, the trephines. Trephination was not a new procedure during the Civil War. There's evidence it's been used since prehistoric times. But these were used to bore a hole into the patient's skull in order to relieve pressure or to remove bone, bullets, or shrapnel that might be stuck inside a wound. And you're welcome. I used drawings instead of actual photographs. So you cut a cross shape into the scalp like you see here in the drawing. Those little triangles are actually flaps of skin that they've pulled back, so that exposes the bone. It's just enough space to get your trephine in there and to drill a small hole into the skull. You could use the instrument itself or a probe or a scoop or, whatever tool is best for the particular situation, to remove fragments of bone or other kinds of things. And then once you're done, you have to kind of clean up the edges. And the Hayes saw, which is the fat one here with the curved top, that was used for that purpose. And here's some of those instruments again. And that's all I have for that one. So the second object I pulled out is an ECT machine. This was a machine used for electroconvulsive therapy, or ECT. It's also more commonly known as electric shock therapy. It was introduced fairly early at Central State Hospital, really shortly after it started being reported in the United States. Two other forms of shock therapies that are lesser known were also used to treat psychoses for a time at Central State Hospital, and that included metrazole shock and insulin shock. These shock therapies induce convulsions and coma, so they're like an artificially produced epilepsy. The insulin shock was introduced first. Insulin had been discovered by two Canadian scientists in 1921. This was pretty huge milestone. It kind of radically changed the prognosis of people living with diabetes. And in 1927, a Polish neuropsychiatrist accidentally discovered that convulsions caused by an overdose of insulin could improve psychiatric symptoms. So by 1934, his technique for treating schizophrenia was being shared in the United States. Initially, there seemed to be a lot of really good evidence of improvement of patients, but it was not without risk or controversy. And it wasn't too long before they started to realize that improvement was not as reliable as they thought, and it was also only temporary. So around the time that this physician was first publishing his work on insulin shock, a Hungarian doctor began experimenting with various convulsant drugs. He hoped to find a way to induce epileptic convulsions that were more controllable, were safer, and more effective. So he tested a handful of substances, including camphor and strychnine. But he landed on metrazole, and that's a circulatory and respiratory stimulant that I believe is no longer in use. So I know there are at least a couple of doctors here who maybe could say more on that. But it was a lot easier to administer. It was cheaper than insulin, but it was not easier to control. The convulsions were frequently much stronger, and injuries like spinal fractures were not uncommon. During the 1940s, the use of metrazole decreased, and finally it was discontinued altogether, both here and elsewhere. Electric shock therapy was developed in 1937 by an Italian neurologist. He thought that the previous shock treatments were promising, but he felt they were far too dangerous and unpredictable. It was also hard to gauge when they would begin. There was a period of time that elapsed between when the drug was administered and when the convulsions actually started, and that was a problem for a couple of reasons. But from the patient's perspective, that amount of time that the patients were still conscious and not knowing what to expect, it really increased the anxiety and fear that the patients felt. And it was kind of a major problem with both insulin and metrazole. Once the convulsions started, you just had to let it run its course. There wasn't a way to stop it in progress if something went wrong. You couldn't intervene. Patients were very fearful of those treatments. These were physically and psychologically traumatic for the patients who underwent them. They were also not a one-off cure. This was something that there would be a series of these treatments, and in some cases you'd have multiple treatments even in a one-day period. Sometimes you'd have 20 of these before your course was done. And so it really caused a lot of stress for patients who were undergoing this. The Italian doctor Carletti that I mentioned, He was a specialist in epilepsy, and his experiments in that area inspired him to develop a machine that could deliver electric shocks to the brain. He and a couple of his colleagues worked to build such a machine and to determine the most appropriate dosage and technique. When used on humans, all of the benefits of the convulsions were noted, but there were far fewer dangerous side effects and risks. It's more reliable, more easy to control. And one benefit of the intracranial electric shock that you didn't see in the metrazole and insulin was the amnesia that it produced. So a lot of patients had no memory of the treatment itself or of the events immediately leading up to it. And so fewer patients developed the severe fear and anxiety of the treatment that the insulin and metrazole had produced. This type of shock treatment was effective in many cases, and its side effects were relatively mild and temporary. And there was evidence that delusions, hallucinations, and catatonic postures often disappeared or at least lessened. Here's a close-up of the machine and the electrode. So there were different types of these electrodes. There were some that like strapped around your head. These are like you would hold it on there, and then they had others that were like handheld that would go like this. In the annual report for 1939, Central State acknowledged the controversy related to insulin and metrazole treatments, which they had hesitatingly introduced the previous year. And they acknowledged the growing sense in the field that these were not all they were cracked up to be. They had attended the American Medical Association meetings and the Psychiatric Association. And so there were all these reports they were getting about how ineffective those other treatments really were and how dangerous they were. So ECT was introduced here at Central State not too long after the news of it began circulating in the US. And soon after that, both insulin and metrazole shock therapies were discontinued at Central State. It wasn't without problems either. Proper restraint and sedation weren't immediately implemented with it. So commonly a group of orderlies or even other patients were enlisted to hold a patient down during the treatment. And it also was not a one-off cure. None of the shock therapies were. ECT was commonly administered to patients multiple times a day, and even some doctors accused its practitioners of using ECT as a means of control rather than healing. And this kind of harkens back to the 19th century when alcohol was commonly used as a sedative for psychiatric patients, and physical restraints like chairs with straps, adult-sized cribs with locking lids, leather straps, and camisoles, which we would know as straitjackets. These were all used often not merely to protect the patients or prevent them from hurting themselves or other people, but rather as something of a babysitter. Patients were often able to return to something very close to a normal life, though, at least for a period of time after treatment. Relapses were common. But it was also noted that in their more accessible state after these treatments, psychology found that it was useful to follow up with psychotherapy for patients who had recently undergone these convulsive therapies. So this is a time when there's a lot of bickering between psychiatry and psychology. And so this was kind of an attempt to use both together and recognize that both have benefits. They also felt that the close observation that patients had after undergoing these treatments made minor setbacks and relapses easier to identify and address. They could sort of address those issues as they came up rather than waiting till that patient was reinstitutionalized because things had gotten so bad. So this particular model of ECT machine was patented in 1951. This is my favorite part of it. There's a typed sheet of instructions taped inside the lid. It plugs into an electrical outlet, has to be warmed up for a short time before it's ready to use. There's some cautionary warnings on here. I did notice that none of the cautionary warnings were about protecting the patients. They were always like, oh, the machine will blow up if you. That's a little bit of an exaggeration, but they were worried about damage to the machine, not necessarily to the patients. And maybe there's a reason why that was not an issue, but I couldn't help notice that. I'm really not an expert on any of this stuff, but you know, basically you smear a generous film of electrode jelly on the electrodes as well as on the temples of the patients, and then you hold the electrodes to it and turn the machine on. And there's advice for what the dosage should be and how often the treatment should be done. There are a lot of references in neurology books and other places too that really go into some detail about that. They also suggest that you use a mouth gag, and also proper support and restraint of the patients, although they apparently leave it up to you to decide what that means and how you will accomplish that. But then you just administer the treatment. As antipsychotic drugs and antidepressants were developed and they increased in popularity, the use of ECT began to decrease in the 1970s. It is still in use today, though. In a lot of ways, it looks different than it did in the 1930s, but it's still around, and there's still some degree of controversy for all of the same reasons. There are, though, a lot of people, including patients, who swear by it, and others who object to its use for various reasons. So that's all I have.